So today we're going to talk about basic chest radiographic anatomy. So our routine views of the PA and the lateral chest radiograph. So the PA chest radiograph is taken with the X-ray beam going from posterior to anterior through the patient. So the anterior portion of the patient is closest to the image receptor, and we do that to minimize the magnification of the heart by putting it right up against the image receptor. The lateral view is taken with the left lateral portion of the patient closest to the image receptor. Again, the idea is to keep the heart closest to the image receptor, and so that then minimizes magnification of the heart. So this is a question for the first years. This is the same patient, no pathology. Comparing the two radiographs, what is different? Which is AP, which is PA?
Based on the scapula, we'll say the one on the left is AP.
Yeah, so the scapula are your best clue. So you see that the scapula are overlying the lung fields here, and then here the scapula are rotated away. You also, in general, the quality of the PA chest X-ray is better than the quality of the AP chest radiograph. So when we take the PA chest radiograph, we also ask the patient to rotate the shoulders forward, and the idea is to get the scapula off of the lungs, okay? Now, this, I think, was covered in physics yesterday. So the PA chest radiograph is taken with the X-ray tube much further away from the patient and with the heart closer to the image receptor that decreases the magnification of the heart, as opposed to the AP chest radiograph, where the X-ray tube is closer to the patient, and it's even this is done in the department, but it's even closer when they do portable chest radiographs with the patient in the bed with the portable units. And so the heart also, again, is further away from the image receptor, and you can see the magnification that geometrically produces magnification. And the formula, of course, was covered yesterday in physics: source image distance divided by source object distance. Something else you need to know is this portable chest radiographs taken with higher kVp. Is that true or false? Any R2s? Is that true or false? Which has a higher kV? Okay. There are more motion artifacts with portable chest radiographs. Is that true or false?
True.
Why is that true? What leads to more motion artifacts with portable chest radiographs?
Maybe the equipment's just not stationary.
Wait, I can't hear you.
The equipment not stationary.
Well, the equipment's not moving.
Maybe the patient is.
So why would there be more motion artifacts from patient motion? Can anybody tell me?
They're like disoriented or something.
Can't hear you.
If they're disoriented or
That could be, but it's because it has to do with the exposure time, right? So the exposure time for a portable unit is longer than the exposure time for a unit in the department. Why is that? Senior residents?
portables are lower key.
Yeah, well, it's not just that, but the generator output, the power output is much lower from a portable unit than it is from a unit in a department. And so the exposure time has to be longer to compensate for that. Okay, and then you also brought up the kV, right, which is part of that. So higher kV is used with PA chest radiographs, and that also helps with the contrast because it helps to burn through the bones on a PA chest radiograph so you can see the mediastinum and the lungs better. So that's why you will notice on your portable views that the mediastinum often looks denser on your portable views. Portable units are not capable of higher kVs because of the limited power output in the portable generators. And then, of course, we talked about why we have more motion artifacts with portable chest radiographs. Okay, this is a question for R2s. Easy. First of all, the easiest thing is which one of these gives you the highest radiation dose? Excuse me?
Chest CT.
Of course, right, the chest CT. Give me an idea between the PA and the lateral, which has a higher radiation dose, the PA or the lateral?
Lateral.
The lateral. So what is the approximate radiation dose for PA for lateral and for chest CT?
PA 0.44, lateral 0.06, chest.
Yeah, his chest is about
80.
Hi, louder, please.
80.
80 millisieverts?
Oh, no, 80.
Okay. Hopefully not 80, right? So the PA chest radiograph is 0.02. It's about, so you can see an idea of the order of magnitude here. So for the PA and lateral is about 0.06. So a good rule of thumb is that a chest CT is equivalent to about 100 chest radiographs. A natural background radiation is about 3 millisieverts per year. And something nobody thinks about, but taking an airline flight cross country is about 0.04 millisieverts. So that's about the same dose as you would get from a chest radiograph. So don't worry about the dose from a single chest radiograph, but realize that, of course, a chest CT is much higher, about 100 times higher than a chest radiograph. So these are terms that we need to be familiar with, things that we're going to cover here on the PA and the lateral view. So the idea is after this conference, you should be able to look at this chest radiograph and tell me what's abnormal. What study would you order next if you were interpreting this chest x-ray? You should be able to look at this chest x-ray and tell me what bothers you here. What are you concerned about? What study would you order next? You should be able to look at this chest x-ray and actually give me a specific diagnosis for exactly what is wrong with this patient. Okay, for this chest radiograph, again, you should be able to look at it, tell me what's abnormal, tell me what you're most concerned about, and actually tell me what service you would recommend consulting next for dealing with this patient's problem. So hopefully by the end of this, you'll be able to do that. So starting with the border-forming mediastinal structures. So everybody together, what is this? I can't hear you. SVC. Over here we have right atrium. What is this guy? Right interlobar pulmonary artery. Right, that goes down to the lower lobe. On the left side, you have 3 bumps that you have to be very familiar with. These are roughly about the same size. The first bump is the aortic knob, right? The second bump. Stop mumbling. Louder. Main pulmonary artery. The last bump. That's the left atrial appendage. Another nice way to find the left atrial appendage, you see where the left main bronchus ends, and then you look just underneath that. That's the region of the left atrial appendage. The rest of this will be left ventricle, right? And then there it is, superimposed. You have that also in your handout. So here's a nice coronal CT showing you the border-forming mediastinal structures, superior vena cava, right atrium. On the left side, the aortic knob, main pulmonary artery, left atrial appendage, rest of the left heart border is going to be left ventricle. Sometimes, if the ascending aorta is tortuous or if there's an aneurysm of the ascending aorta, it can bulge out. Sometimes that right border, instead of being the superior vena cava, can be the ascending aorta. So if we see that, we would think of a tortuous ascending aorta, but you might also consider an aneurysm of the ascending aorta. So again, having covered all of those things, when we look at this chest radiograph, which bump is abnormal?
Pulmonary artery.
So the main pulmonary artery here, right? So here's the aorta, here's the main pulmonary artery, is left atrial appendage. So that is really big. And what do you notice about the size of the right pulmonary artery? It's also enlarged. Left pulmonary artery also appears enlarged. So we have enlargement of central pulmonary arteries. What are we going to be concerned about here? Yeah, so here you're going to be concerned about pulmonary artery hypertension with enlargement of the central pulmonary arteries. Now, what's different about this chest radiograph? Can't hear you.
It's just the left, the main.
So the main pulmonary artery is dilated. What about the left pulmonary artery? It's also dilated, but what's different? The right pulmonary artery is not dilated. So here, what is the next test that you're going to recommend for this patient?
Echocardiogram.
Why?
To look at the pulmonic valve, to see if there's any.
So you're concerned about pulmonary valvular stenosis. What's the pressure in the pulmonary artery in the patient with pulmonary artery stenosis? Is it elevated, normal, or decreased? It is normal, right? So the right ventricle hypertrophies because what happens is that the obstruction is at the level of the pulmonic valve. So the actual pressures in the pulmonary artery are normal. Why is this? Why do we get dilatation of the main and the left pulmonary artery, but not the right when we have pulmonary valvular stenosis?
Because the jet of the stream from the pulmonic stenosis shoots towards the left side, and the right side is more angled, more acute.
So the jet goes into the main and the left pulmonary artery. The left pulmonary artery is continuous with the main pulmonary artery, so that's where we get poststenotic dilatation. The right pulmonary artery comes off at an angle, so you don't get dilatation of the right pulmonary artery. So when we see this configuration of enlargement of the main and the left pulmonary artery, but a normal size right, so here we're going to be concerned about pulmonary valvular stenosis. All right. So the vascular pedicle, what are the borders of the vascular pedicle? What's the border on the right side?
SVC.
SVC. What's the border on the left side?
Left subclavian artery.
The left subclavian artery makes the border on the left side. That's correct. So this patient, in this case, the vascular pedicle is slightly widened towards the right. There's also pulmonary vascular congestion from increased intravascular fluid volume in this particular patient. So here it is on CT. The right border of the vascular pedicle here is from the superior vena cava. The left border up here is the left subclavian artery. So the right border is a venous structure. The left border is an arterial structure. So often we will see it dilated to the right with dilatation of the SVC if there's increased intravascular fluid in that particular patient. So this is the same patient. Here there's increased intravascular fluid. You can see that here's the border of the SVC. In this case, here it's distended more towards the right. And then you can see this oval-shaped opacity, the diameter of that is actually more dilated here on this radiograph than it is here. So what is this oval-shaped opacity?
Azygous.
That is the arch of the azygous vein, right? So that also can dilate if there's increased intravascular fluid or if there's increased venous pressure, systemic venous pressure. So the azygous vein travels up the posterior mediastinum in the paravertebral region. It arches forward to join the superior vena cava. You can see the oval-shaped arch of the azygous vein actually through the shadow of the superior vena cava there, okay? And that can be dilated in some cases. All right, so here I have an arrow pointing to something. So any R2 resident, tell me what's the first thing you're going to think about if you see this chest radiograph? Lymphadenopathy, yes. If you see a rounded structure like that in the right paratracheal region, the first thing you might think about is lymphadenopathy. What else would you consider? What else could give you an appearance like this on a chest radiograph? Can't hear you.
A mass.
Well, mass mostly is lymphadenopathy. What kind of mass are you talking about? You talking about a benign lesion? What benign lesion might do that? Anybody? Can't hear you.
Organs.
Duplication cyst? Possibly a bronchogenic cyst, although the most common location of a bronchogenic cyst is where? Subcarinal, right. But they might occur in the right paratracheal region. Kevin, is this a double aortic arch? Could this be a double aortic arch? Yes or no?
Could be.
Could be? What goes against this being a double aortic arch? Anybody? What do you notice about the trachea? What do you look for if there's a double arch? You look for indentation on the trachea, right? So a double arch is the most common of those vascular ring anomalies that can give you narrowing of the trachea. So if this was double aortic arch, you would expect some indentation of the trachea in that region, but you don't have that here. So what does this turn out to be? Well, what else would we consider here? What else could this be?
Azygous continuation of IVC.
What?
Azygous dilation.
So it could be a dilated azygous vein, okay? What's your differential of a dilated azygous vein?
Azygous continuation.
That's one. Name some other things. Anybody, what else is in your differential of a dilated azygous vein?
Portal hypertension.
So how does that give you dilated azygous vein?
The azygous is one of the collaterals. like one of the,
So you can develop portal systemic collaterals if you have portal hypertension that will give you increased flow through the veins. So that can lead to a dilated azygous vein. What else can give you a dilated azygous vein?
superior vena cava syndrome.
Obstruction of the superior vena cava, also obstruction of the inferior vena cava. Right. So the azygos can act as a collateral route if you have central venous obstruction. Anything that increases intravascular fluid volume, pregnancy, can result in a dilated azygos vein. So elevated right heart pressures, if there's, again, increased pressures within the systemic venous system, can lead to a dilated azygos vein. So in this case, this is a dilated azygos vein coming all the way up there. That's the azygos arch. So that's what we're looking at here. And here is the CT on this case. So what's the diagnosis and how do we know? Well, what did you mention? So is this azygos continuation of the IVC?
Yes.
How do you know?
You see on the right side, the right image, the continuation.
So this is the azygos vein here, but what's the key to making the diagnosis of azygos continuation of the IVC? Absence of the intrahepatic inferior vena cava. So there's no intrahepatic inferior vena cava, right? So embryologically, this represents the azygos vein, which is carrying all of the blood flow from the lower part of the body, and that dilates, comes all the way up and drains to the superior vena cava. So if there's absence of the intrahepatic inferior vena cava, what happens to the hepatic veins? Where do they go?
They find their way back to the.
How? That didn't keep you up at night when you realized that the intrahepatic IVC is missing? It didn't strike you? What happens to the hepatic veins? Oh my gosh, where do they go? So where do they go?
They drain into the SBC.
They drain to the SBC?
Sorry.
They form a smaller IVC, which you can see right here. So the hepatic vein form a smaller IVC, which then drains into the right atrium. So the key to making the diagnosis is absence of the intrahepatic inferior vena cava. Okay. All right. An R2 favorite. What is this? Okay. So what vessel makes the aortic nipple? Can't hear you. An artery. What vein? The left superior intercostal vein, right? So that gives you the aortic nipple. So the left superior intercostal vein here, if it happens to run parallel to the aortic arch, can give you that kind of nodular opacity next to the aortic arch, which we call the aortic nipple. So this vein is draining into what? It drains into the brachiocephalic vein. What is this vessel back here? Where it comes from? What? You're close, the accessory hemiazygos. Okay, so it goes from there to the left brachiocephalic vein. So that is the aortic nipple, the left superior intercostal vein. Okay. All right. The normal hilus should appear smooth and vascular. There should be nothing bulging out from the hilum. Here's the right hilum here. There's the left hilum there. So in terms of the anatomy, what you have is the interlobar pulmonary artery here. This vessel is usually the right superior pulmonary vein coming down, and in between you have the hilar angle, very smooth, nothing bulging out. This vessel here is the artery to the right upper lobe. It's abbreviated TA there. What does TA stand for? What's the other name for the artery to the right upper lobe? Pulmonary. What do we call it? Truncus anterior. Yeah, the truncus anterior is the right upper lobe pulmonary artery. All right. So very smooth hilar angle. And here's the anatomy superimposed. So there should be nothing bulging out there from the hilar angle. The same thing is true on the left side. Very smooth hilum, should not be lumpy, bumpy. Nothing should be bulging out from the left hilum. So here's a volume rendered view from a CT scan. We see the right pulmonary artery. There's the interlobar. There's the truncus anterior. Here's the right superior pulmonary vein. That's this guy coming down here. So you can see the hilar angle in there, very smooth. Nothing is bulging out from there. Okay, so that's what we look for. So looking at this chest radiograph, is there anything that bothers you? Any R2s? Anything bothering you about this chest radiograph?
Fullness of the right.
Okay, so if you were wondering about that, right, what's a radiologist's best friend?
Prior.
Prior studies, right? Rule number 2. So there's the study from a year ago, and now does this increase your confidence or decrease your confidence? Can't hear you.
Increase.
Okay, well, does the hilum look normal here? Yeah. Now there's a little something, there's some subtle bulging out. It does look like there's increased opacity, but there's this little thing bulging out that wasn't there before, and even the density of the hilum is increased compared to the prior study. So what are you concerned about?
Like lymphadenopathy.
So you're concerned about lymphadenopathy, and then on the CT, there is right hilar lymphadenopathy. That accounts for what we're seeing there, okay? And this turned out to be lung cancer, all right? So it's a subtle case of right hilar lymphadenopathy that you can really see on the chest radiograph, especially if you compare with the prior studies. So the bronchial anatomy, you need to be familiar with the segmental bronchial anatomy. The appearance of the segmental bronchi on the CT scan will depend on their orientation relative to the axial CT slice. So the trachea, you're going to be cutting in cross-section, so that's going to appear round. The right upper lobe bronchus will fall in the plane of the slice, so that's going to appear tubular, and then so on as you look at the remainder of the bronchi. So you do need to be familiar with the segmental anatomy. So here we have the trachea, then we get down here to the main stem bronchi, and then we have the right upper lobe bronchus. How many segments in the right upper lobe?
3.
They are,
Anterior, posterior, and
it starts with apical though. Apical is number 1. So apical, anterior, and posterior are the segments to the right upper lobe. So here's the right upper lobe bronchus. That's the anterior segment. That's the posterior segment. We go a little bit above that. Here's the apical segment that we're cutting in cross section because it goes straight up. So here's the right upper lobe bronchus. There's the apical segmental bronchus. Then when you cut right through here, you'll see the anterior and the posterior segmental bronchi to the right upper lobe. When we get below that, we get to the bronchus intermedius. And then below that level, we get to the right middle lobe bronchus. The segments of the right middle lobe are lateral comes first. They're lateral and medial. Those are the segments. Those are the segments of the right middle lobe bronchus. When you get to the right lower lobe bronchus, the first one to come off is the superior segmental bronchus. And then you get this airway, which will supply the basal segmental bronchi. That has a name that's called the truncus basalis. And then that will divide into the basal segmental bronchi, and a nice mnemonic for that is MALP, M-A-L-P. So the first one that comes off is medial basal segment, then you have anterior, and then you will have lateral and posterior. So medial, anterior, lateral, posterior for the basal segmental bronchi of the right lower lobe. For the left side, there is no left middle lobe, so the lingula is analogous to that, but the lingula is part of the left upper lobe. So the left upper lobe in 75% of cases will bifurcate into a superior trunk and a lingular bronchus. And then that superior trunk will divide into the anterior and the apical posterior segmental bronchi. So as we're going up here to the superior trunk, you'll get the apical posterior and then the anterior there, okay? 25% of cases it can trifurcate into the apical posterior, anterior, and lingular bronchus. So here you can see the anterior and apical posterior there, and when we go below that level, that's where you see the lingular bronchus. The lingular bronchus is often at the same level as the right middle lobe bronchus on the other side. So that's the lingular bronchus there. Left lower lobe, very similar to the right lower lobe. You have the superior segmental bronchus, and then you will have the basal segmental bronchi. Often there's a combined bronchus, the anteromedial basal bronchus, which comes off first and then divides into medial and anterior, and then you have lateral and posterior. So the basal segmental bronchi on the left side, very similar to the right. So good exercise you should all practice at the workstations, at the PAC stations, is to scroll through the anatomy and name the segmental bronchi, identify each of the segmental bronchi as you scroll through a chest CT. Okay. All right. So this line over here, Who can tell me what that is? Can't hear you. I still can't hear you. Please speak up. The pleuroesophageal line. Yes, that is the pleuroesophageal line. So if there's air in the esophagus, you may see the right lateral wall of the esophagus against the trachea because there's air in the lung, there's air in the esophagus, and then we can see that superimposed on the trachea. That is the pleuroesophageal line. Okay. What is this? What is the arrow pointing to here? Any senior residents?
The left major,
How do you know that's the left major fissure?
it goes to the left window.
So it goes down to the left diaphragm. How do you know that's the left diaphragm?
It disappears.
Okay, so two reasons you can tell. One, it disappears below the heart because the heart is sitting on top of it. What's another clue that it's the left diaphragm? What's this guy underneath? Yeah, so the gastric bubble is underneath there. The right diaphragm you can see through the heart shadow, and the right major fissure usually inserts more anterior than the left major fissure. Okay, here the arrow is pointing to. So that is a superior accessory fissure. This is the minor fissure. This is the major fissure on the right side. So the superior accessory fissure separates the superior segment of the lower lobe from the remainder of the lower lobe. Here the arrow is pointing to. Can't hear you. No, it's not the azygos is much higher. We're here at the lung base. That's the inferior accessory fissure. So this separates the medial basal segment of the lower lobe from the rest of the lower lobe. So there's the inferior accessory fissure. And then you can see that sometimes on a chest radiograph also. That's the inferior accessory fissure, separates the medial basal segment. So these are accessory fissures that you may run into. This guy over here is, that's the pleural reflection over what? Phrenic nerve, right. So that's the pleural reflection over the phrenic nerve. So we can see that also at the lung base. On the right side, it's related to the inferior vena cava. There it is on the left side. This patient also has an inferior accessory fissure, right? So here's the inferior accessory fissure. There's your pleural reflection over the phrenic nerve, okay? So the pleural reflection over the phrenic nerve, we can see that there. The inferior pulmonary ligament is usually related to the esophagus. So the esophagus would be there. That would be the inferior pulmonary ligament. And then the pleural reflection over the phrenic nerve on the right side is related to the inferior vena cava. All right, so those are those lines that you might see at the lung base. Here the arrow is pointing to what?
Trigonum parietale.
So what is the trigonum parietale?
It's fat.
It's extrapleural fat that sneaks into what?
The azygos fissure.
The azygos fissure. How does an azygos fissure form? Why do we have one?
So the azygos starts lateral embryologically and then pulls pleural down.
Yeah, so embryologically, the azygos vein, the arch of the azygos vein starts more superiorly here. And then as the lung grows around it, it kind of migrates down to its position above the right upper lobe bronchus. But if it happens to be a little bit too far lateral, as the lung grows, then it starts to cut through the lung and comes all the way down here. Often the arch of the azygos vein, when you have an azygos fissure, doesn't get all the way down. So it winds up more superiorly than you usually expect it. So how many layers of pleura are in the azygos fissure? 4. They are
2 parietal, 2
correct. 2 parietal layers and two visceral layers. And so they wrap actually around the azygos vein at the bottom of the fissure. So the triangular opacity at the top is called a trigonum parietale that represents extrapleural fat that sneaks into the azygos fissure at the top. And so when you have an azygos fissure, the arch of the azygos vein often doesn't make it all the way down, so you'll see it more superiorly than normal. This is called the azygos lobe, medial to the azygos fissure. It's not a true lobe or a segment. It doesn't have a separate bronchial supply. But you have here the azygos fissure. Here's the azygos vein found at the bottom of the fissure. And then the azygos lobe here will be medial to the azygos fissure. This line is, that is the anterior junction line. So that's where the pleura meet anteriorly from the right and the left lung. So this starts below the level of the clavicles and then it disappears where the heart is because the heart sits in between the lungs. So that is the anterior junction line. So here it is, the anterior junction line on the coronal view. So that comes down and then that disappears where the heart is. So that's the anterior junction line. Okay, so we agree that this patient has a shifted anterior junction line. Why is the anterior junction line shifted? Mass effect from what?
Anterior mediastinum mass.
I can't hear you.
Anterior mediastinum mass.
Well, the anterior mediastinum looks pretty good on the lateral view here. I don't see it. It's a very nice one of the better clear, external clear spaces you're going to see. So I really don't see an anterior mediastinal mass. So why is the anterior junction line shifted? Is it shifted to the right or the left? Shifted to the right. So what does that suggest?
Collapse of the middle lobe.
So there's right middle lobe atelectasis. How do you recognize that there's right middle lobe atelectasis on the radiograph? There's opacity on the right here. So there's volume loss on the right. You see the heart shifted to the right. There's opacity on the right. It obscures the right heart border. So that directs you to the right middle lobe. But what is the really nice finding here that tells you there's right middle lobe collapse? Yeah, there's a triangular shaped opacity overlying the heart on the lateral view. That's the collapsed right middle lobe. So whenever you see a triangular opacity like that over the heart on the lateral view, or any opacity overlying the heart on the lateral view, that's going to direct you to either the right middle lobe or the lingula, right? And if it's triangular like this, then that's the typical appearance of atelectasis of the right middle lobe. This line is that is the posterior junction line. So that usually starts above the clavicle and then it ends where the aortic knob is. This patient also has an anterior junction line. So you can see both the anterior junction line here and the posterior junction line in the same patient. The patient has emphysema, which is why these lines really stand out in this particular patient, right? So that's the posterior junction line. And then here it is on CT. So this is where the lungs meet posteriorly. That is the posterior junction line. Okay. This line here is that's the right paratracheal line. And notice that you can see it through the shadow of the superior vena cava. The normal thickness, it should be less than 4 millimeters, about 2 millimeters. But that is the right paratracheal line. And on a good PHS radiograph, you can make it out and you can see it actually through the shadow of the superior vena cava. The oval-shaped opacity here represents, that's the arch of the azygos vein, right? So here's the normal right paratracheal line, and we will see that because there's air in the trachea. There's the right lateral wall of the trachea. There's air in the right upper lobe. So that gives you then this nice opacity of the right paratracheal line. Okay, so here's the current film that we're looking at. There's the radiograph from 5 years prior. Is there anything that concerns you?
There's thickening of the right paratracheal.
Okay, so here you can see the right paratracheal line through the superior vena cava. Here you can't see the right paratracheal line. There's all of this increased opacity in the right paratracheal region. So there's increased opacity in the right paratracheal region. So what are you concerned about? What do you think this could be? What would do this?
Mass.
What do you mean mass?
Oh, so I believe in that region, usually of like neurogenic.
Is that a neurogenic tumor in the right paratracheal region? Is that the most common cause of a right paratracheal opacity? So what should he be concerned about?
Lymphadenopathy.
Lymphadenopathy. So thickening of the right paratracheal region, the first thing you might be thinking about there is lymphadenopathy, especially if there are no other findings. There's no deviation of the trachea, nothing extending up, right? So there you'd be concerned about lymphadenopathy, and there is right paratracheal adenopathy here on the CT. This was metastatic lung cancer that was presenting as right paratracheal lymphadenopathy, right? And you can, again, but it's important to compare with old films, and that makes you more confident that there's something abnormal in this patient. Sometimes you can't see a left paratracheal line if there happens to be lung adjacent to the left paratracheal region. All right, so one of our favorite games in chest is where is the mass? So where is the mass? Well, is it on the right or the left?
Left,
All right, it's on the left. We're on the left.
left apex.
Okay. So there's something abnormal opacity up here, right? So localize that for me. Where would it be and how do you know?
Because it goes above the clavicle, it would be posterior.
Posterior, right? We can see the lateral border above the clavicle, so that implies that it's posterior. What sign are you using? What do we call that sign?
Cervicothoracic.
Cervicothoracic sign. So what's the first thing in your differential diagnosis for this appearance on this chest radiograph?
Neurogenic.
Neurogenic tumor, right. So pat yourself on the back. You diagnosed a neurofibroma on a chest radiograph, okay? So let's have a hand. Okay, very good. All right, so that's an example of the cervicothoracic sign. Now, what's different about this case?
You don't see it above the clavicle.
What's that?
You don't see like.
This time there's opacity on the right side, but we don't see the lateral border above the clavicle. What does that imply?
It's anterior.
That it's anterior and it's blending in with the soft tissues of the neck. So what's the first thing on your differential diagnosis for this?
Thymoma.
Thymoma? Why is thymoma not a good answer?
It's too high.
It's too high. So what's the first thing in your differential for this chest radiograph?
Thyroid.
Thyroid mass. What's another clue that thyroid mass should be the first thing you think about here?
The trachea.
There's deviation of the trachea. So whenever you have deviation of the trachea with the mass extending down from the thoracic inlet, especially when the lateral border disappears, you have to think of a thyroid mass, thyroid goiter extending down into the mediastinum. What else might be on your differential for this chest x-ray? I mean, the thyroid mass should be number one, but what else might you consider? Yeah, so lymphadenopathy from any cause, right? Sometimes that might also give you an appearance like that. But the first thing you should think about is a thyroid mass, especially if there's deviation of the trachea. And that indeed was the case here. This was a thyroid mass extending down, a thyroid goiter. Okay, so the cervicothoracic sign, if the lateral border disappears, you think of an anterior mass, as in this case, especially if there's deviation of the trachea, thyroid mass. If you can see the lateral border above the clavicle, that means it's more posteriorly located since it's interfacing with lung, and there you can go through a differential of posterior mediastinal masses, especially neurogenic tumors. Okay, this line is, what do we call this line? So that's the aortic pulmonary reflection. So that is the pleural reflection against what? Against the anterior mediastinum. What lives here?
Thymus.
The thymus lives there. All right. The AP window, that's this area just underneath the aortic knob, between that and the left pulmonary artery. Notice it's commonly concave there towards the mediastinum. It can be concave or straight towards the mediastinum. There should never be anything bulging out from the AP window. Right? So the AP window, marked by the asterisk here, is that little area between the undersurface of the aortic arch and the left pulmonary artery. Okay, and then this line we talked about the aortic pulmonary reflection there. So the AP window, this little area over here, the arrowhead's pointing to the aortic pulmonary reflection. So AP window, that little area right there, you can see on the coronal view between the undersurface of the aortic arch or knob and the left pulmonary artery. So often there are tiny lymph nodes in there, but there should not be anything bulging out from there on the chest radiograph. So now on this chest radiograph, what are we concerned about? What bothers us? Consolidation, opacity, what? Given that we just covered the AP window, what are you concerned about here?
Probably fluid overload.
What is this thing? There's a big mass here in the aortopulmonary window. Okay, so most common, so you're concerned then about what? Can't hear you. Well, what else do we see on the X-ray, on the chest radiograph?
Could be meds, metastasis,
Well, what else is abnormal on the chest radiograph?
multiple metastasis.
Well, what are you going to call these opacities? What do we call round opacities in the lung? Nodules, yeah. So we have bilateral lung nodules with this mass here in the aortopulmonary window, right? So the mass in the AP window we suspect might represent lymphadenopathy with bilateral lung nodules, so we're concerned about malignancy here, okay? So looking at the CT scan, here's our mass in the AP window, right? We think that's lymphadenopathy. Do we see lymphadenopathy anywhere else? We don't see lymphadenopathy anywhere else? Can't hear you. Supraclavicular? What about on this image?
Like a pre-treat.
Precarinal. Yeah, there's precarinal lymphadenopathy here. What's peculiar about the lymphadenopathy? What do you notice here about the lymphadenopathy? Can't hear you.
Enhance.
Yes, there's enhancing lymphadenopathy here. So Sawan is going to give us a very nice differential now of hypervascular metastases. Carcinoid, renal, thyroid. What's that? Choriocarcinoma. Yeah. So any types of, those neuroendocrine tumors can give you an enhancing that's. So for this particular case, of the things you mentioned, what do you favor and why? Anything about the last image that helps you here, Sawan? Yeah, the thyroid is missing. So this patient has status post-thyroidectomy for thyroid cancer. So this is recurrent thyroid cancer presenting with hypervascular metastases. Okay. Okay, where is the mass? Well, what sign is demonstrated? Yeah, so the hilum overlay sign here, you can see the pulmonary artery through the mass, right? So that's a hilum overlay sign. What does that tell you about the mass?
Anterior, posterior.
It's either anterior or posterior, so it's not in the middle, so it's not a hilar mass. So in this particular case, is it going to be anterior or posterior? How do you know? Which is it, and how do you know?
Anterior is part of the clavicle. Could you apply that principle?
That's the cervical. Well, first of all, that's the cervical thoracic sign, right? But This mass does not extend above the clavicle to be able to use that sign, right? The mass has to extend above the clavicle first to be able to use that sign.
We can see the aortic knob.
So we can see the aortic knob and the descending thoracic aorta through the mass, right? So what does that tell you? Tells you what?
The mass is posterior.
That the mass is posterior? Is the knob, the knob and the descending thoracic aorta, are those anterior or posterior structures? Those are posterior structures. They're not silhouetted, which would tell you that it's probably not posterior. But what's the best sign here that the mass is anterior? Well, what is obscured by the mass?
The heart.
The heart border. The left heart border here is obscured by the mass. So that tells you that the mass is anterior, obscuring the left heart border. So this then is an anterior mediastinal mass. What's on your differential?
Teratoma.
Well, you want to go through the 4 T's, go through them.
Okay, thyroid.
Wait, hold on. Are you going to say thyroid for this?
Oh, not for this one.
You're not going to say thyroid for this. Why?
It's too far down.
Yeah, it doesn't extend up into the neck. So we don't like thyroid for this. So what are we left with?
Lymphoma.
Lymphoma, yes.
Probably not teratoma.
Well, not teratoma, right? Because what would you look for teratoma? You'd look for fat. But along that line, what is in the differential?
Thymoma.
The thymoma is certainly in the differential. But what else would be in the differential? You said not teratoma, but what would be in the differential? What would be? What else would be? She said lymphoma. She said not teratoma. That's the clue.
Germ cell,
Germ cell tumor. What kind of germ cell tumor?
non-seminal.
What?
Non-seminal.
No, seminoma is actually the most common malignant germ cell tumor of the anterior mediastinum. So not teratoma, but a malignant germ cell tumor. Seminoma might be in your differential for this case. Particularly why?
Breasts.
Well, that's the embryologic cause, but I'm saying why for this particular case would you include it in your differential if you're reading this CT scan? What?
Looks like a young male.
Can't hear you.
Looks like a young male.
I still can't hear you.
Looks like a young male patient.
Yes, because it's a male patient. All right. The malignant germ cell tumors of the anterior mediastinum do not occur in females. But in a male patient, if you have an aggressive anterior mediastinal mass, in addition to lymphoma, you might also consider a malignant germ cell tumor in the differential for that. Okay. This was a thymoma. What's different about this? Where's the mass?
More posterior this time. Silhouetting that area knob.
So this is obscuring all of the hilar vessels here. So here you're concerned that this is in the hilum, right? Because it's obscuring all of the hilar vessels. You can't see the pulmonary artery. It's extending into the AP window. And so this turns out to be massive lymphadenopathy that's extending from the hilum there into the mediastinum. What's in your differential for this case?
Still like lymphadenopathy.
Well, it is lymphadenopathy, but what's in your differential? What disease is? Lymphoma. Anything else? Can't hear you.
Mediastinal fibrosing.
Fibrosing mediastinitis is in your differential for this CT scan? I don't think so. Anything else besides lymphoma? That's all you can muster for this? Well, of course, it could be metastatic disease, right? From what? Well, what's the most common cancer that occurs in the chest? Lung cancer. So what kind of lung cancer? Can't hear you.
SCC.
What?
Squamous cell.
So if I asked you for a type of lung cancer that you would put first, if you saw the CT, you would say squamous cell.
Oh,
Is that what you'd say?
no, I mean,
What should she say? Small cell. This was small cell cancer. Small cell is the most aggressive of the lung cancers. So if you have large central mediastinal mass lymphadenopathy and you're thinking about lung cancer, usually small cell is what you would be thinking about, especially if the patient's a smoker. All right. This line is that's the azygoesophageal line. So that is the pleural reflection against the esophagus and the azygos vein along the mediastinum. The lung that goes in there, that's called the azygoesophageal recess. Okay, so the pleural reflection against the esophagus and the azygos vein, that's the azygoesophageal line. It travels up there and then it disappears, goes away where you have the azygos vein arching forward. Okay, so for this particular patient, which of those mediastinal lines is deviated? Of the lines we discussed. Yeah, so the azygoesophageal line here is deviated to the right, and then here's the right atrial border, here's the descending aorta, there's the left paraspinal line, there's deviation of the azygoesophageal line here towards the right. Okay, so can you provide a specific diagnosis then for this patient?
achalasia.
Achalasia, yeah. So this represents a distended esophagus. So here the esophagus is distended with fluid and air, and that's what's causing then the deviation of the azygoesophageal line to the right. So when there is achalasia, the esophagus dilates, tends to flop to the right, and that can give you this dilatation or this deviation of the azygoesophageal line that goes all the way down. Okay. All right. Right paravertebral line. Again, the compartment there is going to be posterior mediastinum, and we have the right paravertebral line. And we also have left paravertebral line. So there we're talking about the posterior mediastinum. There's your left paravertebral line. Okay. Descending thoracic aorta, left paravertebral line. Another interesting appearance is that you get a negative Mach effect when you look at the descending thoracic aorta. Notice it's kind of lucent adjacent to that. As opposed to the paravertebral line, it's kind of dense. You have a positive Mach effect. And that has to do with the shape of the interface relative to the lung. So if it has this convex interface, then you get this negative Mach effect, and then this more of a concave interface, you get a positive Mach effect. But that's another way to differentiate the descending thoracic aorta from the left paravertebral line. There's a difference in the Mach effect that you get with those two lines. Okay, so what line is deviated? By the way, when you take the core exam, I understand there's a lot of radiographs on that exam, and they ask you to put the arrow on the abnormality. I suspect a lot of those abnormalities might involve deviated mediastinal lines. So what lines deviate? What? Yeah, so the left paravertebral line, what compartment is that? Posterior mediastinum, first thing on your differential. Neurogenic tumor, right? So that's a neurofibroma here causing deviation of the left paravertebral line. The lateral view. So we need to be familiar with the anatomy on the lateral view. So this guy is the aortic arch there on the lateral view. This round lucency, what is that the arrow is pointing to? What's that round lucency? What is that round thing?
Left upper lobe bronchus.
Yeah, it's the left upper lobe bronchus or the left main bronchus, depending on the particular patient's anatomy. This common shaped structure that goes up and over that bronchus is, that's the left pulmonary artery that goes up and over the left upper lobe bronchus. This round, funny shaped opacity here is what?
Hilar complex.
Yeah, it's the right hilar vascular complex. It's a fancy term. Most of it is superimposition of the main and the right pulmonary artery, but it also involves pulmonary veins. That's why it's called the hilar vascular complex, that round, funny-shaped opacity there. So you can also see the outflow tract sometimes on the lateral view, right ventricle going to the outflow tract of the right ventricle, pulmonary outflow tract on the lateral view. So notice the left upper lobe bronchus, there tends to be vascularity surrounding it, the hilar vascular complex, the left pulmonary artery. but it's kind of bare underneath. So there's a bare area underneath that. This line that's bisecting the left upper lobe bronchus, what is that line?
Posterior wall.
That's the posterior wall of the bronchus intermedius, and we see it because on the lateral view, the bronchus intermedius projects over the left upper lobe bronchus. So on a well-taken lateral view, you will see the posterior wall of the bronchus intermedius projecting over the left upper lobe bronchus. So as we've said, when we look at the left upper lobe bronchus, there's vascularity all the way around it, but there's this kind of bare area underneath. That is called the infrahilar window. Right, so normal infrahilar window here underneath that left upper lobe bronchus. Okay. By the way, this round lucency just above that, what is that? What am I pointing to? What's the round lucency above the left upper lobe bronchus on the lateral view?
Right up.
That's the right upper lobe bronchus, right? This bronchus here, what is this bronchus? It's the anterior wall of which bronchus? Well, if that's the left upper lobe, that's going to be that left lower lobe, right? So that's the anterior wall of the left lower lobe bronchus on the lateral. Okay. The bite out of the donut, there's vascularity surrounding the left upper lobe bronchus, but the infrahilar window is avascular. So I like to think of that as taking a bite out of a donut. So you should not see complete donuts on the lateral view. If you see complete donuts, it is abnormal. So here's a complete donut. This patient has subcarinal lymphadenopathy. There's a left hilar mass. So the donut sign, usually a sign of subcarinal mass or lymphadenopathy, if we see that on the lateral view. This patient has abnormal opacity in the right paratracheal region. The hilar look rather full. On the lateral view, there's a very nice donut telling us there's something wrong in the subcarinal region. So there's a nice donut sign. There's subcarinal opacity there, which represents subcarinal lymphadenopathy. And then we also have bilateral lymphadenopathy. So what's our diagnosis for this case? Sarcoid, yeah. There's right paratracheal and bilateral hilar lymphadenopathy, and it's very common for them to also have subcarinal lymphadenopathy. What is this line?
Posterior tracheal stripe.
Yeah, so that is the retrotracheal stripe that marks the posterior wall of the trachea, right? So you can have air that gets behind there from the right upper lobe, and then you will see the posterior wall of the trachea, retrotracheal stripe. In this particular case, what's abnormal? Well, we just mentioned the retrotracheal stripe. What do you think of it here?
It's thick.
It's abnormally thickened, right? So what are we concerned about? What lives behind the trachea?
So
The esophagus, right? So what's the diagnosis? What? What do you think the mass is? What's the first thing on your list? Can't hear you. Esophageal cancer, right? So esophageal cancer. By the way, this patient has a complication of esophageal carcinoma. What's the complication? What's the complication of esophageal cancer that this patient has? Perforation. There's contained perforation here. Okay, so it's a patient with esophageal cancer and a contained perforation. Right? So the pulmonary outflow tract, we can see that also on the lateral view. This patient has massively enlarged central pulmonary arteries from pulmonary artery hypertension. Why does this patient have PA hypertension? Can't hear you.
COPD.
COPD, right. There's extensive emphysema. Right, so this patient has PA hypertension with COPD. Right ventricle is also dilated. So you can see the enlargement and the encroachment on the retrosternal clear space by the enlargement of the outflow tract. Here's volume rendered view showing you the encroachment on the retrosternal clear space, right ventricle and pulmonary outflow tract in this particular patient from dilated pulmonary arteries from COPD. All right. This particular chest radiograph, what's bothering us here? Heart's big. Why is the heart big? How do you know it's a pericardial effusion?
Where, same,
What do we call the sign?
it's either a sandwich or.
Sandwich sign or Oreo sign, right? So this lucency is what?
The epicardial.
That is epicardial fat, right? This lucency out here is mediastinal fat. What's in between? That's the pericardial effusion. So the sandwich sign or Oreo sign on the lateral view, on the frontal view, kind of a water bottle appearance of the heart, but the sandwich sign is a specific finding for pericardial effusion. So sometimes you can actually see the normal pericardium if you have enough epicardial fat, mediastinal fat. That thin line is the pericardium. If that is thickened, we think of pericardial effusion. Okay. The arrow's pointing to SVC, right? That is the superior vena cava. Here the arrow is pointing to IVC, right? That is the inferior vena cava. 3 relatively clear spaces on the lateral view. The first one is retrosternal clear space. The second one, Rader's triangle, or that's the retrotracheal space. What are the borders? It's called a triangle. What are the borders of the triangle? The anterior border is the trachea, the posterior wall of the trachea. The posterior border is the anterior border of the vertebral bodies. The inferior border is the aortic arch. Those are the borders of Rader's triangle. Okay. And number 3, retrocardiac. Right. So those are the 3 clear spaces generally on the lateral view. Of those 3, which one is filled? Which one has an abnormality? Yeah. So what compartment is that? Anterior mediastinum. What do you think that is? This turns out to be a thymoma, right? So that's in your differential. It's a kind of a nodular mass, smaller nodular mass that you might go with thymoma. For this particular case, which of the clear spaces is filled in? Yeah, so something in Rader's triangle. What do we think that something is and why? What do we notice about the shape of the trachea here? There's a smooth anterior bowing of the trachea. So if we see something in the retrotracheal clear space with that smooth anterior bowing of the trachea, what should we consider? Also, notice on the frontal, there's kind of a funny opacity there. What do we think about here? What vascular anomaly? Aberrant? Which subclavian?
Right, left.
Which one? What side is the arch on? So which subclavian would be aberrant? No. The aberrant subclavian is the side opposite the arch. So if you have a left arch, it would be an aberrant right subclavian. All right? So that's an aberrant right subclavian artery that goes behind the trachea and the esophagus, and that can cause that smooth indentation on the trachea. So when we see that on the lateral view with something back there, you can think of an aberrant subclavian artery. Okay. What's your diagnosis for this chest X-ray?
It's like spine sign.
There's a spine sign, right? So what's your diagnosis? Pneumonia where? Where's the pneumonia? Left lower lobe, yeah. So the spine sign, also the left diaphragm is obscured on the lateral view. You should always look for both diaphragms on the lateral view. We can see the right diaphragm, we can't see the left. There's a spine sign, so there's left lower lobe consolidation, which you can also see on the frontal view. That's what the normal lateral view is in this patient. Here's what the diaphragm should look like. Here it's obscured. This is a patient with left lower lobe pneumonia. Spine sign, something is in the retrocardiac space here. Normal, that's what the patient should look like. This is the patient with the left lower lobe pneumonia. Okay. Some test cases. Comparing the prior study to 2 years prior, what's abnormal? I can't calm down any more than this. Anybody?
bulging.
What is this area in here?
Oh, you're in pulmonary.
What do you notice about the EP window on the current X-ray? There's something bulging out. See it? There's something bulging out of the AP window, right? So what is that something going to be? Lymphadenopathy. So what's your diagnosis for this patient? Here's the lymphadenopathy bulging from the AP window. What's this patient's problem? So who can tell me what's the problem with this patient? Why does the patient have lymphadenopathy in AP window? There's an endobronchial mass, right? Right here. See it? So what do you think that is? Now you would say,
Cancer.
what kind of cancer?
Oh, SCC.
Squamous cell cancer, right? It's an endobronchial lesion. That's squamous cell cancer. The referring physician comes to you and says, what about these nodules? Are these metastatic nodules to the lungs? What are you going to say? What are you going to? You're going to shake your head back and forth?
Um,
What?
like dream, but
Yeah, they look tree and buddish. They're central lobular kind of ground glass opacity. So that's bronchiolitis from obstruction of the airway. Okay, so it's not metastatic disease. All right. What's abnormal here? Hilum overlay. Who said hilum overlay? What?
Is that high over?
Well, what's abnormal on the X-ray first?
Let's see. Air bubble on the left heart.
So there's a retrocardiac opacity that contains air in it. Okay, so the most common cause of a retrocardiac opacity with air in it is, you said, hiatal hernia. Right. So that's a hiatal hernia. Okay. This patient has fever and back pain. What service gets consulted next? What's abnormal? What are we concerned about? What? Yeah, the paravertebral line here is displaced. So here's the azygosophageal line. Paravertebral line is displaced. What compartment is that? Posterior mediastinum. Given the history, what are you concerned about? Paraspinal abscess. So you might want to consult neurosurgery, right? So there's discitis with osteomyelitis, and that's a paraspinal abscess. That's what's causing bulging of the paravertebral line. Okay. So where's the mass? Well, there's this big thing over here, but where is it? What? There's a, can you see, is it a hilar mass or not?
Actually, no, you can see the.
Yes, so there is a hilum overlay sign. You can see the pulmonary artery through it. So it is not a hilar mass. That means it is what? Either anterior, posterior. Which is it?
It's obscuring the aorta.
It's obscuring what?
Oh, the right heart.
It obscures the right heart border. That means it's going to be where?
Anterior.
Come on. Anterior, right. So we have a hilum overlay sign, obscures the right heart border. It's an anterior mediastinal mass. What's in our differential for this? What do we notice about it? Well, what's striking about it on the CT?
It's low density.
What density is that?
Fat density.
Yeah. So it's a lot of fat density. So what's in your differential here?
A lot of fat, teratoma.
Not teratoma. Teratoma tends to have foci of fat, but the whole thing is usually not fatty. It's too much fat for that.
Lipoma.
Lipoma?
Yeah.
Well, there are some soft tissue elements in here, so probably not lipoma, but low-grade liposarcoma. You need to be concerned about that. But what else would be in your differential for a large fatty anterior mediastinal mass?
Thymoma,
Not thymoma, but what do we call it?
thymal,
Thymolipoma. Thymolipoma would be the differential. So this was a low-grade liposarcoma. And of course, this is going to be, all of you should be really good at this by now. Posterior mediastinal mass using application of the cervico-thoracic side, right? So that was a neurogenic tumor, okay? All right, so next conference, there will be a quiz on this, so prepare for that.